Okay, good afternoon. Thanks for coming, and thanks Amy for organizing this, Amy and Pete. It's really a nice event. I'm a cardiologist at Minneapolis Heart Institute. I've been there for 21 years, and I'm going to tell you a little bit about my story in the body of the talk, how I got interested in these conditions we're talking about today. I'm an echocardiographer, and I'm joined by my vascular and cardiovascular surgeons who are also going to follow me and offer their perspectives as well. So we're going to talk about thoracic aortic aneurysms. How did we define what's dilated? What do we do when we recognize them? We're going to talk about, as Gretchen said, the ER evaluation and what we as clinicians think about and how patients need to be their own advocate. We're going to talk about the program that we have to rapidly diagnose and treat these patients if they present with a dissection, and we're going to touch on the long-term management in the next 30 minutes. So when I give this talk, I think about Da Vinci, okay? And I used to think of Da Vinci as from the Mona Lisa. But as I started to read about him, and I discovered that he was the first person to describe the flow above the aortic valve and the flow in the aorta, and he made these corollaries to the flow in rivers. He was a very interesting guy, and especially in this disease, where we are curious, we're seeking knowledge, we're trying to understand, we're not taking any kind of standards, and we are avoiding silos. I often am working with my genetic counselor, my cardiac surgeon was drawing a picture of an aortic sinus for me this afternoon, my vascular surgery colleagues. So we all are sharing our knowledge, and you as the patients as well, to what we can do better. And that's kind of what we're talking about, and I think it's a very collaborative field. So we have guidelines. When we as physicians talk about how we're going to treat people, we rely on these guidelines, but the American Heart and the ACC guidelines are actually, they're kind of old at this point, 2010. European guidelines are a little newer, and then we have imaging guidelines as well. So when I talk about guidelines, this is what we're talking about. I'm also going to talk about the IRAD group, and I've been fortunate to be a member of this group since 2005. And this is 30 centers around the world, and we share information about our patients, patients' consent to research, and we analyze the information. So we can answer a question, and instead of looking at it at our center, we can answer the question in 4,000 patients, for example. So that's been very important, I think, in advancing the knowledge in aortic dissection. So I think probably we have a very knowledgeable audience, but just to review, this is a dilated aorta. We start right here at the sinuses, and this is the aortic sinus. We have the ascending aorta. This is an aneurysm, the arch, and then there's a dissection in the descending aorta. That was a patient that presented to us with the type B, a distal dissection. So what's an aneurysm? So an aneurysm means there's dilation of the blood vessel compared to its normal diameter. Usually these are silent. There's no symptoms associated. And they're often detected incidentally. Patient will come in, they'll get chest x-ray or some other test. And it's fortunate, like Amy said, for whatever reason, however the diagnosis is made, the patient is made aware of the condition. Sometimes with a very large aneurysm, it'll push on abutting structures and cause symptoms. But that's not the general rule. So when I, in the echo lab, am making a measurement, I try to report it in the sinus and in the ascending aorta, and sometimes at the sinotubular junction. And it's important that when we make these measurements, we measure them perpendicular to the flow, and we measure it so it's clear to the next person that's looking at it where we made the measurement, and we make comparisons to the prior measurements. I like to use techniques that minimize radiation, so MRIs and echoes are the preferable techniques. But it's also important when we talk about the aorta that we're talking about what's normal for this patient. So if you have a 70-year-old man here and he has a 4.2 centimeter aorta, that may be normal for him, okay? But that's not normal for a young woman. So this is where some of these nomograms, when we interpret the data, the echo data or the CT data comes in handy. I think Gretchen touched on some of these conditions. I'll skip over this, and Dr. Bowen, I think, is going to talk about this later as well. So bicuspid valve is very common, 1% of the population. As Gretchen alluded, we screen the relatives. They may actually have dilated aortas, they may have valves, they may have both. And surgical thresholds, this is probably one of the most common questions I get is what is the threshold? And there was some confusion by the various guideline committees, but at least right now, the consensus is that the surgical threshold for a bicuspid valve is 5.5 centimeters, unless you have other reasons to do surgery. If you are diagnosed with an aneurysm, we have guidelines for athletes. What is okay for you to do? What kind of activities are safe? And we know that athletes may have a little bit larger aorta than others, but this shows the distribution in the NBA. So the NBA does echoes every year on their players, and most aortas are relatively normal for these very tall individuals. Surgical thresholds are generally around 5.5 centimeters, but that's not a hard and fast criteria, as I'll talk about on the next slides. If you're getting an aortic valve replacement, I think it's important to consider it at 4.5 centimeters. But this is why the 5.5 is probably not a perfect criteria. This is from our IRAD group, and it looks at the distribution of dissections, or the size at the time of the dissection. So 5.5 is our criteria, and the hashed bars indicate sizes that are less than that 5.5 centimeters. And so 60% are actually less than 5.5, 40% are less than 5 centimeters. And we know, this is our own data, that the aorta increases at the time of the dissection. So in our imaging labs, our readers have started to report a newer criteria, which is the aortic cross-sectional area to height ratio. This is a newer paper. They look at these survival curves. There's a blue curve, which indicates an area less than 10. The green curve is that the ratio is greater than 10. It's not a perfect study. There's a lot of weaknesses in the study, but it's another tool that we use when we're trying to counsel our patients when they may need surgery. I like this paper, which tries to spell out for the individual with a dilated aorta, what is their risk of an aortic event. And as you can see here, so if you have a 5 centimeter aorta, your risk of an aortic event over the next 5 years is about 1%. So when I see a patient with a thoracic aortic aneurysm, I work on their blood pressure. I try to use beta blockers, ideally, as a class of medication. I'll use ACE inhibitors or ARB medications, other blood pressure drugs. I talk to them about their smoking, statin. I talk about, if they go into the emergency room, that they have to advocate for themselves. We talk about weightlifting. We get the screening organized, and I usually do the first follow-up image in about 6 months. So we're going to transition here to talking about thoracic aneurysms, to talking about the acute situation. So Fred Hoiberg, and his story is unique. He was playing college basketball. He had an echo, part of a screening. Years later, when he was going to have kids, the life insurance examiner said, hey, you need another echo, and he had a very dilated aorta. He was playing professional basketball at that time, and that basically ended his playing career. He's now a basketball coach, and it's actually worked out okay for him. John Ritter, not so fortunate. I got this picture from his widow, Amy. He had a heart scan, like a calcium scan of his chest, wasn't aware that his aorta was dilated or it needed to be followed, and ended up coming in with abdominal pain, which is the manifestation of his dissection. And he died. In this picture, he's with Lucille Ball, who also had a dissection. So I'm going to present a case, and this is a patient I met just this week. And although I've been talking about this condition for 15 years, there's still cases like this that are out there. Okay, so this is a woman. She had a history of hypertension. She'd actually had prior echo. She'd had a PFO closure. So we had plenty of echoes on her. And her aorta was normal. And she had hypertension, not taking meds. And she woke up with severe, intense pain. She said it was like a ripping sensation. And she had this altered sensation in the lower part of her body. She went in the ER. She'd taken a fall the day before. She'd had an alcoholic beverage, and she was quite hypertensive. The ER felt comfortable because they could reproduce the chest pain by pushing on her chest. She had normal pulses. They did a troponin, which is a marker of heart damage, which is normal. Chest x-ray was normal. And so the only thing they found was an elevated creatinine, which is a marker of kidney function. And they did an MRI of her spine. And then they sent her home. Is anybody comfortable with that? So she was told to follow up with her primary, and she did. So the day after Christmas, she went back to see her primary, and her creatinine was even higher. So the primary drew some labs, and then the following day called her and said, you know, the creatinine's even higher, go back to the ER. And she was still very hypertensive. She'd been taking a leave, I think, throughout the week because of pain. And this, they did a non-contrast MRI of her abdomen, which showed this rim of fluid in the aorta, this crescentic thickening of the aortic wall. But when they scanned her chest, they also saw this flap in the ascending aorta here, which you can see here. So she was fortunate. She survived for a week with a dissection. So Dr. DeBakey, who we're going to talk about in a few minutes, said no physician can diagnose a condition he never thinks about. And why is a dissection a problem? Well, patients can have rupture of their aorta. So this is the tear right above. This is a series we did with the Jesse Edwards lab, which is a local but nationally known pathologic registry. There's a tear right above the aortic valve. But most people that die from aortic dissection, they have a tear in their adventitia. So right here, there's a tear in the outer wall of the aorta, and about 60% of deaths just occur suddenly. The patient has a dissection at home, they never make it to the ER, and they die. So what we learned is that 1% per hour of patients that are having dissection will die. And that was data from the 1950s, before there was cardiac surgery for this. We looked at that recently in our IRAD registry, and it's still about 1% per hour. So surgery makes a big difference. So we try to get the patients into surgery once we recognize it soon. King George II collapsed on his commode, and his physician diagnosed him as the first patient with the aortic dissection. Dr. DeBakey, right here, did the first successful operative repair of dissection, and he did many repairs over the course of his career. So when he was 98 and he was retired, he suffered a dissection at home, and he waited it out for a couple days, and then one of his trainees convinced him to go in and let him repair it. So he was the oldest living survivor of the operation that he devised. So when we talk about dissection, we have the proximal dissections, type A, if it involves the ascending aorta. And Dr. Moody is going to talk about the surgical repair of those. Those patients should go for surgery. And then we have type B, so distal dissections beyond the subclavian. So Dr. Manunga will talk to us about that. So when we see patients in the emergency room, and if you think about an emergency room, patients are coming in all the time with all kinds of symptoms, including chest pain. So it's very difficult for an ER physician to always get it right, and so they rely on blood tests ideally. We don't have a great blood test for dissection, although D-dimer is pretty good. But we need to look at what are the things that predispose you to this, this condition. And these are the high-risk conditions. So if you've had a thoracic aneurysm, as we've been talking about today, a family history of a thoracic aneurysm, Marfan or some other connective tissue disease, or if you have aortic valve disease, or if you've had aortic manipulation, which includes cardiac surgery, it might include a catheter in your aorta, maybe as part of a heart catheterization. Those are all conditions that set you up for aortic dissection. The history, usually people are pretty sure there's something seriously wrong when they come in. The best story I ever got was the first one. So I was a resident in New Hampshire by myself at night, and a physician came in. He was actually a vascular surgeon, and his wife said, he's having a dissection. And I didn't really know too much about it at that time, but he was right. I called in the guy that became my echo mentor, and he did a transesophageal echo, and diagnosed him with a dissection. He went for surgery and did fine. But you're never going to get history like that. But the patients generally know the pain is severe. It's maximal in onset. This patient that I saw this week described ripping pain. I think that's a little bit less common. But the path of the dissection determines the symptoms. So John Ritter had abdominal pain. Patients may have pain in their leg or pain in their neck if it dissects into those vessels. But you can also have painless dissection. Patients just pass out. We as the clinicians, when we examine the patients, sometimes we're reassured because we check their pulses and they're okay, but that can be a marker of dissection. Patient may have a murmur, which I'll show you some pictures, which indicate a leaking valve. The patients may have, they're often hypertensive, but they may actually have a low blood pressure. And they may have neurologic signs like the patient I presented. But it really depends on the course of the dissection. So the ER clinician who's trying to rule out bad things takes this information from the pre-existing conditions, the history, the exam, and tries to decide who gets imaging. So the American Heart says if you have a couple of those things, you should go straight for a CT and notify your surgeon. But any of those things really are enough if you have a patient with chest pain to be thinking about dissection. We know that in our IRAD group, the time from ER arrival to the diagnosis is 4 hours. It takes 4 more hours to get from the diagnosis to the operating room. And it depends which hospital. If you're at an outlying hospital, it may, there's transfer involved, it may take even longer. So years ago, 2005, we got people together and said, this is a high-risk condition. We need to coordinate the care and integrate it. So we have a process in place. So if somebody comes in with a dissection, if they come in Abbott or if they come in Mora, Minnesota, we want everybody treated the same way. So we got a number of physicians together. So we have our cardiac surgeons right here, these guys. We have our vascular surgeons. We have our emergency room physicians. We have radiologists, cardiac anesthesia. We really depend on our cardiac imagers. And we actually kind of all got together. The people have changed, and I'm going to introduce you to my enthusiastic and young colleagues who have really taken this to another level. But we formed what we thought was the ideal care pathway for dissection, and includes when the clinician suspects dissection, and then once it's confirmed. And we thought what was lacking was delays in diagnosis. Patients weren't getting the same imaging. They'd get an abdominal CT and not the full CT. They weren't getting the right medicines. There were delays in getting the patients down, delays in getting them to the OR. And so we addressed each of these things. And I'm going to show you some of the results that we had. And then we went out, once we had our protocol, we went out and gave talks around Minnesota to these small ERs and just kind of said, hey, if you have a patient, troponin's negative, just think of dissection, and this is our algorithm. So once we diagnose a patient with a dissection, page goes out to all these people. This is coordinated through our ER. We have checklists in place, and we have orders in the electronic record. It's called Epic, where we can click and get an order set to get the blood products ordered, the medications, for example. The ER physician is involved, so when the patient is transferred, Cambridge, Mora, Blue Earth, wherever the patient's coming from, they land in the emergency room. The surgical crew gets ready, and then when they're ready, they bring them up to the operating room. And we have a very collaborative approach. You'll hear from my colleagues. For the type A, the cardiovascular and the vascular surgeons are both involved. And for type B, the vascular surgeon takes the lead with cardiology. So it's a very multidisciplinary approach with these hybrid techniques, which they will talk to you about. So our initial results from this, as I indicated, the medications were not ideal in the patients before we had this protocol in place. All of our patients now get beta blockers, both at arrival and then at discharge from their dissection. They all get transesophageal echoes. This shows a picture of a dissection flap prolapsing across the aortic valve. And so all of our patients get transesophageal echoes in the operating room, which quite frequently changes the management that the surgeon takes towards the valve, which I think Dr. Moody will talk about. And we, with this protocol, and just as basically a systematic approach, improve the times that it takes from the diagnosis, or from the arrival to the diagnosis, which is on the left side of the slide, and from the diagnosis to the operating room. So to summarize the total time here, so it used to take 500 minutes, let's say, from the patient to get into the ER till they get into the operating room. And we've basically cut that time in half. And that 500 minutes is fairly similar to what we see around across the country. So we've cut the time in half by about 6 hours. So for a condition with a 1% per hour mortality, we think we're making a difference. There's other programs that have come out since ours, like the Duke program, and they've shown survival benefit over time. Once the patient makes it through the hospital stay, we know that these patients are at risk for long-term sequelae, such as the development of aneurysms, rupture of their aorta, recurrent dissection. And so we follow them very systematically. And we do annual imaging. We see them back and talk to them about their blood pressure. We talk to them about screening their family members, do genetic testing when needed, and talk to them about their lifestyle and work restrictions if necessary. And we've now shown that by the patients coming back to see us, we can decrease their subsequent events, and the survival is actually significantly higher in the patients that are coming back to see us. So just to present since I showed you a case that was not maybe handled the best way initially, this is a little bit better case I got from Dr. Manuga. It was a 66-year-old man, came into the ER with severe chest and abdominal pain. His blood pressure was low. His lactate was high, that's a marker of malperfusion. And I think at that point there was a discussion, should we even do anything? Dr. Manuga and the cardiac surgeon explored him to see if his bowel was still viable. And they decided it was. And he underwent a Bentall procedure, which Dr. Moody will explain that in greater detail. And then a distal stent. This is his aorta before the surgery. This is the, oops. I think you can appreciate there was a tear in the ascending aorta as well as all the way through the descending aorta. And this is after they've repaired him. The aorta is back in place, and he's doing well and continues to see us in clinic with the stent graft in his descending aorta. We have all of our protocols on our app. There's this MHI app that we have, and it has our emergency protocols as well as other resources such as how to handle anticoagulation for various surgery. So that's all available. But I think patient advocacy, as we're talking about today, is a very important thing. There's a number of good organizations out there, and I used to really dread when the patients come in and they've Googled their condition, but there's so much good information out there on the Marfan website, and really so many other good resources that patients are finding. It actually makes for very good, educated discussion. So anyways, that's all I have. I think we'll be doing the questions later, and Dr. Moody is going to join us next.